It's very exciting to be here tonight. My name is Seth Keller. You can see my name up on the cover here. And my backstory is I am a developmental neurologist. I live in the Philadelphia area, and I am in New Jersey. And New Jersey, just where I live, is right across the bridge, so I'm close to my home. I have been working in the field of developmental disabilities for quite a number of years, and I do work also for Special Olympics. I'll probably discuss my involvement with Special Olympics as we go on in some capacity. I'm the past president of the American Academy of Developmental Medicine and Dentistry, which is a national healthcare organization specifically dedicated to the healthcare needs of adults with intellectual and developmental disabilities. And my other forte as a developmental neurologist is I am very much interested in geriatrics and aging related issues, particularly towards neurologic problems, and I'm the co-chair of the National Task Group. I would love to spend a whole time talking specifically about what the National Task Group is, but be it as it may, we're a group within a group of the AADMD focusing specifically on the issues related to adults with intellectual and developmental disabilities who are at risk or who have dementia. And so what I'm going to do is I'm going to kind of give an overview of what it is that I have planned for tonight's chatter. The backstory, I'll give some more background as to what I would like to kind of cover about myself and the big issues in large. And I'm going to spend a little bit of time on each of these different bullet points. What I want to really get across is the issues of aging in the intellectual and developmental population, the concepts of functional decline, Down syndrome and dementia, and a really important aspect is what's going on now in the United States as well as the various states around the country, even Alaska. I did some homework to understand about Alaska and what they might be doing within your own backyard in terms of age-related issues. And most of the end point is going to really focus so much on Special Olympics and the concepts of the aging athlete. My background, aside from developmental medicine, is I was an athletic trainer back in my younger years, in my younger career before medical school, and I love sports. I'm very much love sports. I wish I was athletic. I'm not. I love to watch and be around sports. And as a prior athletic trainer, I certainly appreciated a lot about health care, health promotion, and what it takes for an athlete to be able to maintain their ability to function and stay at their best, and also to appreciate what it means for an athlete, and specifically a Special Olympic athlete, to be very much engaged in the game, participating, and make it a whole life important issue for them, and how it affects them and their lives and their families. I work with Special Olympics. In my years in the American Academy of Developmental Medicine and Dentistry, I work with the leadership of Special Olympics, and also I work within the Healthy Athletes program, both not only in New Jersey but also nationally. My colleagues are more inclined to work directly more than I do. I've been through training, train-the-trainer, and I've done a lot of work both nationally as well as in the state of New Jersey. But the issue about seniors and aging, it's a huge issue for me. Within Special Olympics, and I've been, I wouldn't say carrying the torch, that would be probably a poor use of terms, I suppose, about trying to really raise awareness. That would, I guess, be a better way of putting it, about aging athletes. And my perception, and I'm going to certainly be curious about people on the phone who have a lot more years in Special Olympics and involvement of the realities of the Special Olympic athletes, is what happened to them as they begin to age and develop through their later years. And the rhetorical question is, what happened to them in any way, shape, or form as they age? And my perception, and I would love to say that I had lots of data, and maybe you guys can talk about data in Alaska, is what happens to the aging athlete they stop performing, they stop being able to compete. I wouldn't say they drop off the planet, but a number certainly do. And I think, again, the bias of my perception is really what I know about Special Olympics is the focus hasn't been much on the aging athlete and what happens to them or try to keep them involved, but it's been so much of the focus in the earlier years of the younger population with the young athletes, the younger ones now who are with a new program involved in Special Olympics. But the importance of aging is really only because of the fact that the reality is that those with intellectual and developmental disabilities are living longer. And for those that have been around the block a while, they can certainly appreciate maybe when they were in their early years in the field of developmental disabilities to realize that, hey, look, we're having a lot of people, God bless health care and the ability of giving them attention for their lives. But the estimates are that in over the course of decades, it's an incredible increase of those that have been living longer. And in 2002, the particular information that is on the slide really talks about 640,000 or so were just over 60,000, and 75% were in the age group between just 40 and 60. However, the baby boomer, just like people with intellectual and developmental disabilities, is increasing in an incredible large way, and that's certainly the same thing with people with developmental disabilities. And really by 2030, the numbers of people who are sticking around longer, who are aging, is going to go up double and triple over the next decades. So it's important to try to get on top of the curve of what's happening with the aging population, because we're going to see more and more people with intellectual and developmental disabilities be around and participating, or at least trying to participate, which is really the issue at hand. Particularly in Down syndrome, just to give some generalities about age and those with Down syndrome, the top graph really looks at those with general ID, in the black line, and the pink line is Down syndrome. And in people with Down syndrome, even back in my goodness, this starts back in around 1930, only about people really only lived to around age 10, believe it or not. And as you can see, the curve over the decades, and this stops just short of 2000, but it continues to go up with data after that, shows that people now with Down syndrome are living well into their 60s. And intellectual disabilities just generally also continue to increase their life expectancy. And about 25% of persons with Down syndrome are alive at over 65. And again, looking at the data in the slide, you can see that's a huge change about it. And so really the issue is that back in the day, even a number of decades, even back in the 80s or even before that time, aging-related issues really weren't thought about. The focus on attention for those with intellectual and developmental disabilities was really maternal fetal health, early development, trying to focus a lot on their lives when they're younger, and thinking forward about, my goodness, someone with IDD, Down syndrome in particular, is going to, wow, even thinking about how they would be in their 50s and 60s and beyond. There really wasn't a lot of research and science, because there really weren't a lot of people around at that point that age to that level. So with the information about age and change in IDD and Down syndrome, there really wasn't a lot of information. So the attention toward focus and thinking about the aging populations, even going back to look at the beginnings of Special Olympics, there wasn't a lot of thought about it because it really wasn't an issue, because sadly enough, in reality, people with IDD just really weren't living as long as they are now. But things have changed. Things are definitely changed. The realization, and this will be, I suppose it'll be no shock to anybody on the phone call, and I could certainly take a poll on everyone on the call and ask each of you about your own personal age-related change. I'm 53 years old, lucky me, and I'm 53, And I'd like to tell you that I haven't changed a bit. My hair is the same, my skin's the same, my eyes the same, but I'd be kind of lying to you. I mean, right now there's no video, so I guess I can say whatever I want. You could take it for what it's worth, but we're all friends here, and I'll be honest, I'm being funny. But age is reality, as you all know, and this again comes as no shock. We're all going to age, and the issues related to our physical state, mental state included, it's going to happen. And these are predictable. We have a certain expectation, whether you deny it or not, about what to expect as you get older. Age does have certain changes that do occur. You don't know exactly the X on the calendar when my skin will change, my eyes will get worse, my hearing will get worse, my memory won't be as good. It's going to happen. And these declines are really expected. We have a certain pattern of what we consider that normal or not. And when things happen in a quicker way, or we expect it in a different kind of way, then that's where some of the red flags come up and say, my goodness, boy, I don't think I should be like this at this point. I didn't think I'd be like this until much older. So this rings true for a lot of things. Sensory changes or sensory loss is referable more towards hearing and vision changes. Musculoskeletal is the changes with our bone structure, arthritis, things related to our balance too. And people with motor and neurologic and other significant comorbidities are because of the fact that they have a baseline of lesser abilities or impairments in specifically intellectual and developmental disabilities. They are impacted a lot more because they already have a baseline deficits to begin with based on the level of problems they already have. And that'll be important. As a neurologist, I spend my daily life talking so much about the brain, of course, and memory, learning, and behavior as much as what I do in my daily life. And really the things that are actually normal age-related changes is the increased difficulty just getting words out. Sometimes we just don't find the right word. Sometimes multitasking becomes somewhat of a difficult, and then decrease in ability to even just pay attention is actually normal. However, as we age, we can still learn. We can still create new memories, and we can still improve our vocabulary and language. So all is not lost as we age. However, it certainly does become more difficult in a normal fashion. But we do also know that in a normal fashion that these things do worsen and they become problems. So the question will be, when is things not normal? When do things show up in our lives, or people that we know or families are changing and they're a sign of something bad, specifically like Alzheimer's or dementia? That'll be interesting to talk about, and I'll broach that shortly. IDD and aging, well, here we are. So the issue about folks with IDD and aging, which is a huge issue for my life and what I do, and hopefully for the future in Alaska, is really the realization that in age-related disorders, they are superimposed upon the context of what it is within the social structure of their lives, their mental and physical difficulties. And as a neurologist, I certainly know that age-related change, it's difficult. The diagnosis is very difficult to often know what these changes mean, and sometimes to really know for sure if they're abnormal or not. So there are lots of challenges that really go into the assessment and following people, interventions about how to care and how to improve people, the treatments and therapies that we often try to provide for people with intellectual developmental disabilities who are aging are often challenging. And then part of it is really related to the fact that there's not a lot of providers who really know what to do about this. I'm not going to speak about Alaska or people that you all may know, but I know that in my own backyard and nationally in the organization that I work with, it's a fact that the health disparities exist tremendously within IDD in general terms, about understanding about people with IDD, understanding their values and respect for them, understanding their conditions or comorbidities, understanding about the social structure at which they live, and in IDD and aging, understanding about aging parents and the issue about the social support system that they are under creates a lot of difficulties not only for them, but for the families themselves and the support network that they're in. The difficulty is a huge issue in terms of the social setting, both nationally and state, because of the fact that there really our system is often not set up to really deliver the care for those with, say, IDD and who are aging, because there's a silo effect that has been often out there in the United States and in most states of the country, about a silo between disability services who are looking for specifically caring and supporting people with developmental disabilities, but also the aging side, which might be looking at over age 65 in general populations and not really think about collaborating or working together. So there's a lot of difficulties that have arisen over the course of the United States, and I'm going to talk about the challenges that have begun to be tackled in some respect by changes within policy within our government, and I'm going to talk about that. People with IDD have themselves difficulties understanding age-related changes, the appreciation of what hearing changes or bone changes or balance changes, and sometimes these changes may be reflective on changes in behavior. They may not see or hear as well, and sometimes the behavior manifestations which can be overtly affected might be more related to not really appreciating that the change that's happening to them is really negatively affecting them, and the only way some people with IDD might be able to react is some overt negative behaviors, and sadly enough, in many cases, people may not appreciate that the problem that they're experiencing is some kind of age-related phenomena, and all the caregivers and physicians and maybe nurses and other folks see is overt bad behavior or difficult behavior, and the treatment will be directly related at the behavior and not what's really going on inside of them. Why are they acting this way? What is really changing within them that is making them have their difficulties? So that does create, lots of difficulties and problems. The concept of functional decline, which I really want to spend a little bit of time talking about, is really the realization that when people begin to lose their function in their daily lives, that's really talking generally about what would be deemed functional decline, where they had a certain level of a function that they're able to perform, say, their activity of daily living, their quality of life was measured in a certain kind of way, but when they begin to change and decline in function, they're not able to perform at the same prior level. And the difficulties can be really separated by both cognitive and physical, and I have a slide after that that really does reflect some of the details of how I, as a neurologist, may try to separate out the differences and try to understand about functional decline and why change and decline is occurring. People with IDD absolutely do present in ways medically or behaviorally when they're compromised in these terms. It's very common. This is a busy graph or busy slide that really talks about what I would call the, say, differential diagnosis. At the top it says functional decline, and immediately underneath that across, going from cognitive, sensory, neuromotor, psychiatric, all the way to medical issues, really talk about all the different reasons why decline, and this is for everybody. This is not just for those with IDD. This is for everybody, us included on the phone call, why we may change. So when I see someone who comes into my office and they're brought in or they're told to come in because they're changing, not able to do what they used to do, and they think it might be a neurologic issue, I think of all these different things. And I sort of have to, in my mind, separate out, are they changing, say, from a cognitive standpoint, because maybe they're having underlying dementia, which is the talk we'll be doing more about. Have they had multiple strokes? Was there head injury? Are they having seizures? Are they not able to perform in their function, maybe because they can't hear or see, or their balance is off? Are they having problems with their tone, which is under neuromotor? Are they having pinched nerves? Are they having neuropathy? Are they declining and not able to perform their function because maybe they're having behavioral issues, depression, psychotic disorders, bipolar, self-injurious behavior, anxiety, and a whole slew of general medical issues which really can be quite prevalent that really lead to change. And one on the bottom, it says ADR. Well, what ADR is adverse drug reactions. And that's something that I find is really significant in a lot of people who have IDD or maybe other population, where the medication that they take for the right reasons perhaps, or maybe not, are causing them some kind of adverse side effect, and someone with IDD may not be able to explain that they're more tired. They might not be able to explain they're dizzy. They may not be able to explain that they're now off balance, and maybe it's because of medication. and all anyone would see in their situation or life that they're off, they're different, and may not particularly be able to pinpoint that, gee whiz, maybe it's these medications that they're on. In many cases with people with IDD have a lot of comorbidities and a lot of different medical issues and behavioral issues, and in some cases they might be on dozen or so medications for all these various reasons, and interactions may be hugely difficult for them. And the primary doctors and nurses, they may not be able to appreciate all these difficulties that occur. But so that's kind of really one of the challenges. So I do look at functional decline in a way that is very relevant. Alzheimer's disease is kind of where I live my life, and the one thing that's very relevant is the fact that Alzheimer's disease is extremely prevalent in people who have Down syndrome. And on the right side, it has percentages, and it goes right to the bottom, 30s, 40s, 50s, 60s. By the time people may reach 6 years old, approximately 60% of people with Down syndrome may have already developed Alzheimer's disease. That's huge. It's certainly not 100%, but certainly as people live even longer and healthcare is able to maintain people's health, it could be by the time people reach in their 70s, it's a huge majority. This is absolutely such a larger, way higher than it is in non-IDD or other populations where it's certainly never quite this high. So it's huge. It's a huge number. And it's sad in a way when you look at it, because people who have Down syndrome or any form of IDD who are wanting to achieve the best in their lives, perform athleticism and compete, and every facet in their lives surrounding them has been very proactive to try to get them to be in their best and try to give them support, and it's great, they got a future, they're going to be able to do well. A bomb hits. It's all of a sudden they're not able to function, things change. And that's really where I live my life in terms of dealing and working and caring for people who all of a sudden have a devastating change of a news that they're now developing, even in their 40s, they could be developing Alzheimer's disease. Women have a higher risk. There's some propensity towards hormonal changes. There are people that have a course of Alzheimer's disease and Down syndrome that can actually be just for several years. I have taken care of a number of individuals that from the very sign of it change up in 3 years, sadly enough, they could have been passed away. I have absolutely seen that. There can be these rapid changes, but often it's not that quick. Usually it could be any time from diagnosis up to 8 years, but even 8 years, my goodness, that's really terrible. Seizures are often common. So when I see someone with Down syndrome and any form of intellectual developmental disabilities who may have never had seizure before, and then all of a sudden they start having new onset seizures in their later life, that's a change. That's an effect on the brain that's now changing. And that really implies that something bad going on. And one of the things that happens is often degeneration of the brain, which is what Alzheimer's is. And the last bullet point is a busy point, but it really talks about why Down syndrome. What is it within Down syndrome that leads to the propensity to develop the early onset Alzheimer's? And it has to do with that extra chromosome. The third chromosome leads to too much accumulation of the beta amyloid, the protein that's actually made through the genes on chromosome 21, leading up to clogging and destruction of the neuronal structure in those with Down syndrome. And that's absolutely why people with Down syndrome have a higher rate. That extra chromosome, besides it forming their physical state, their cognitive dysfunction, the propensity to have hearing changes, the propensity to have early leukemia or heart disease, it also does give them the higher rate of developing early onset Alzheimer's. It really does. It's important to appreciate, as you might know, why the people change. And for me as a physician and really as a healthcare provider, it really does determine about am I treating them? If I'm going to treat them, I really need to know what their cognition is, because I, as a physician, I'm offering therapies. I need to know if they're having decline in their function to determine the need of support. Can their family support them? And I'm going to talk about a lot about Special Olympics. What can Special Olympics do to support the individual who has declined, maintain their ability to function in sports, health promotion added to that, and certainly assessing people This is very important to understand their level of functioning, their ADLs, and the level key again. And the last point is all about support and educating the support team on how to appreciate the age-related change or dementia, on how it's affecting them. And because there's a predictability about where they're going to go with dementia in people with Down syndrome and Alzheimer's, is to really predict that in a year or two, if they live that long, they're going to be a progression of their difficulties, and prepare and try to be able to take care of them as they progress and make some plans. What we've done, this is going to a tool that we use within the National Task Group. It's called the Early Detection Screen for Dementia. And I have everything I'm showing you on tonight's presentation is all available online. And the link, I can always show you this afterwards, but it's on these slides, and I can have my slides available. What this is a tool that we've developed off another strategy that really enables us and staff and family and organizations to be able to, it's a red flag. That's what the EDSD is. It's a red flag. It actually talks about in the questionnaire, and this is just showing the first page, it's a questionnaire that says, has this individual changed their ability to communicate? Have they changed or lost some function in their ability to walk, or have they lost their ability to remember? And all it does, it says, have they changed, yes or no? And all it does is it notifies that there's a change that's happened to people, and then once the change has been notified, we usually think about doing this on people with Down syndrome starting at around age 40. That's when most people can, who have Down syndrome, really begin to notice changes that could herald Alzheimer's disease. We don't do this every year. But so at age 40, we recommend for agencies and families and around the country for people to do this on a yearly basis, and once change is noted, to take that information to a healthcare provider who can then say, why? Why is this change really happening? Is it normal or not? Are there underlying difficulties within that individual that actually may be dementia, but maybe not? Maybe they're thyroid, maybe they're hormonal, maybe it's hearing loss, maybe they can't see as well. And the important part of the EDSD, because it's around the country and we also use this around the world, it's in multiple language. We have up to 7 languages that this has been made into. Aging and changes in aging and health is not new, certainly to us in Special Olympics and in the IDD community. This slide talks about what our government is doing. The Administration of Community Living, and this I'm just showing you a copy of the page that I just pulled from their website, talks about the realization about age and health of the brain. And this is a website that delves a lot into the impression upon the brain and the changes that can happen. And it's really trying through our government trying to give people, citizens of the United States, information about age-related changes. So this is information that's actually relatively new this past 2 years, and does give information to people who go on the website to talk about age-related change and how they can do the best they can. It does delve into issues of health promotion and some degree of sport activity in the general population. Our government also, through Health and Human Services, talks about the guidelines. They release a PDF online. It's called the Physical Activity Guidelines for Americans. And it really does talk about the realization, and this will come as no surprise to anyone on the phone with Special Olympics, about the importance of health, what it really means for people not only to maintain their physical health, but also to enjoy life and be happy and affect their quality of life in a positive way. And it's realization within the same document that talks about the activity of older adults. That's number 5. It's chapter 5. That's to the right. And it's also within the same guidelines. It's delve a lot. So the issues of aging, change, and trying to stay on top of the curve and trying to avoid or see what can be done with keeping people from, having these age-related difficulties, or at least keeping it slower, is something that is huge, as everyone can appreciate. No one wants to get old, and if there's something you can do to keep yourself younger in mind and spirit and soul, why not? And that's something that is really relevant to this information. This just came out also through the National Institute of Aging and NIH. It's called Go for Life. And again, this is all online. And it talks about the same thing: exercise, safety, people being motivated and try to exercise. You can see some seniors doing their doing some walking and through the pretty woods, it looks like, in the fall. So there's a lot of information that is out there by our government to try to really help us get information. Well, Alaska too, and this is what I pulled up just from local in the state, it has, and this is not just Alaska, of course, it has its aging services. The Aging and Disability Resource Center in Alaska also has information specifically that does talk about, because it's aging, talks about similar information that's put out by our government, but does it in terms of local issues within the state of Alaska. So there's resources, and off to the right, there was a link that actually did talk about IDD. It did, when I looked at it, it didn't seem to talk as much about age-related issues as it did about various amounts of support through a waiver program in Alaska that was talking about it. In the same vein, through the HHS in Alaska is the Commission on Aging, which, as you can see just from the print, healthy body, healthy brain, sound familiar? So that's something too, that's information that's online within the local state that does talk about the information. Well, hopefully I impressed for the realization why Special Olympics should care about age. It's inevitable. It's going to happen. It's not going away. It's only getting larger, and the age-related difficulties that happen are becoming more and more obvious. So for any organization, Special Olympics specifically, it makes a lot of sense to basically develop a program dealing with both normal and abnormal age-related changes in many respects to what Special Olympics is all about. And the rest of the few slides that I have is really going to talk about that. Participating in sports certainly is difficult, not only for those with IDD, but for anyone. Competition is certainly more difficult. Just participating and then being competitive is very difficult. So if you're staying in the same type of sport activity and you age, it's certainly going to become more problematic to be able to compete with other peers that are younger than you. It's almost like unfair. You're being handicapped in some respects. People with developmental disabilities leave Special Olympics as they get older, and I'm going to talk about that, like why. It's like a rhetorical question. What happens to people when they age out? Does it mean it's all related to their health? No. There's a lot of psychosocial issues, as everyone who works in Special Olympics knows in some respects. They have their own experiences. Where do they go and why do they go? Exercise, diet, health promotion, huge. There's lots of data that really do talk about the benefits of health and diet and exercise towards the changes to reduce or slow some of the natural difficulties in our lives as we get older. I talked about assessment. I think it's huge. I think there is clearly an assessment that can be done during the Healthy Athletes program that can absolutely be incorporated into Alaska and every other state to be able to assess people in a very regimented way of knowing about age-related changes and ask questions and be able to assess them. And if age-related changes occur, then certainly within the program of senior athletes, which I deem it called the Senior Athletes Program, is to make the recommendations on how for them to proceed and to be able to continue on in their lives within Special Olympics. Moderation and competition, the addition or more of health promotion as they age. And then certainly part of a healthy communities network is huge. I as one who works in not only Special Olympics, but within the neurologic community and aging community, appreciate what I need to do to kind of reach out to my colleagues who are working in, say, the community in aging. I know that I need to work with physical therapists. I know with social workers. I need to work with families. I need to work with some of the national and local and regional organizations. So I do know that in myself and my abilities, I can only do what I can do, and I'm much greater for the individual, the patient, my individual I care for, that they're better off if we do it in a holistic approach, multidisciplinary approach, and getting a lot of people involved, which I would think it would be in the heart of what healthy communities is all about. So why do people age out, as I say, in sports? Well, maybe they lose interest. Maybe they can't get to the games. Maybe they don't have the support either from the agency or the aging care provider. They decide maybe now it's time to, instead of focusing on sports, job and health programs. Maybe there's other things they're doing. And maybe just a normal functional change of age has made it difficult for them to kind of continue to participate. But certainly in my presentation, talking about abnormal functional decline, including dementia, absolutely. I mean, absolutely. That's a huge reason why people drop out. But is that just the way it has to be? Is that the way that we just accept it to be, or can there be a proactive approach that Special Olympics should do? Well, you know how I feel about it. Cultural aspects. I was talking to my colleagues around the world, and certainly in the United States, about people from different cultural aspects, whether it's Native American, indigenous populations, whether or not they're Hispanic, African American. All different cultures have a different feeling about how athleticism and aging-related changes occur. So certainly when developing a program or thinking about age, having to take into the context of cultural sensitivities around your area is huge. It's huge, as you might appreciate, especially in Alaska with indigenous populations. So I'm sure that's a huge issue that is important to appreciate. This is kind of a busy slide. I'm just have a few more slides, and I'm going to be done and open it up. What are the goals? Well, this is what I made up. I mean, this is certainly by no sense, you know, the hard and fast goals of what any program should be. I think one of the goals is really, the goal is just to realize that it's happening. You know, I think that's the key thing. The goal is probably education and awareness that age-related change happens and people should be aware of it. So it's what I do nationally, and I think anything in a program that people to take it to heart that a senior athlete program should even be available, you have to sell the idea. Here we are doing a promotion, a presentation. That's what I'm doing. I'm really, you know, going beyond, and I want to ensure that people on the phone and everywhere else I talk to really do realize that this is a big issue and there's something that actually can be done, and is a positive thing. It's a wonderful positive thing and ahead of the curve. Absolutely. So enabling adults to continue to, aging adults to compete, to try to keep them around, to try to give them the spirit of competition and health promotion within the framework of Special Olympics. My goodness, absolutely. That's absolutely. Let me go back one slide here. Absolutely. I think that's very important. Let me go back here. Let's see. Whoops, sorry about that. Screening, I do think the goal of any senior athlete program really is screening. I definitely think that screening people for change is very important, and it absolutely can be done. Once change happens and we do look for people declining, there is an ability to collect serial functional data. How can we, and there is ways, and this is another topic into itself, how can we begin to accumulate data that shows level of function that's lost in people? And it really is related to the activity of daily living. When people begin not to be able to perform their activity of daily living as well as they used to, what happens is the care support, the families have to do more for them. There's an inverse relationship to that. So that can be looked at. It can be qualified in some way. Working with families, community-based organizations, absolutely part of any senior athlete program. It's not just within Special Olympics. It's really connecting in a huge way to kind of make the best of the situation. Connecting with the network and partnering with IDD, aging, dementia groups, huge. And certainly trying to market and promote a program like that, like we're developing, I think is certainly inherent within it to try to get the message out, but also it's also the goals and to determine whether or not the program that's begun, does it really achieve what we want it to achieve. Like anything new that we do has to be tested, it has to be tried out, and if things don't really get us what we want, it's not achieving the goals that we like, well, you go back and you look at yourselves in the mirror and say, look, maybe we really need to rethink how we are doing this, and maybe we need to kind of change it a little bit and try to move on from that. I definitely think screening, as mentioned, is very important. I do think the EDSD, which we use, could be incorporated within the screening process for healthy athletes, and if recommendations should be made if decline is really suspected. Serial assessment is very important, and this is again very similar in what I was just talking about, just kind of repeating it one more time. And how do you do this? Well, there are ways. How do you assess change? How do you look for pathologic versus normal change? How do you know where to go when you notice these changes? These are all, again, things to think about. Every health system has a problem when you have cognitive change, and what do you do about it? If their gait is impaired, if they develop some heart-related difficulties, if their bones are osteoporosis, if they are changing, if they have emotional difficulties, each of these can be relevant to aging, and therefore there can be adjustment made in the program for the individuals, again, to kind of not only understand why it's happening for their better good, but also
to appreciate that they can be kept, playing longer and be able to maintain their health in the proactive way that Special Olympics, I'm sure, can definitely do it. Understanding that aging and functional loss absolutely will and can impact their sports, their competition within performance. And now in the future, it's definitely important. And family community organizations definitely have a big impact upon them. So it's a matter of how do you deal with that? How do you deal or work with an aging parent that they themselves have their own physical problems? Where does the role of Special Olympics, other community organizations help them so that'll help the individual that they're trying to support? How? And it's definitely ways that we can do it. This is really just briefly, I kind of was thinking about some kind of algorithm, and this has to do with specific cognitive decline. So in a healthy athlete's assessment, the first box would say loss from prior baseline of function. Well, when a change happens, does that automatically mean that it's real? Does it really mean that it's a constant loss of function? Not necessarily. Sometimes people don't perform very well, and that's to the right where it says loss is not consistent. So maybe they had a bad day, there's a variability in performance. Well, guess what? We'll just test them next year and see if they do lose function next year. But if they do show a consistent loss in function, then the role of really healthy athletes is refer them for a workup. They should be assessed for the changes happening. But certainly keeping them within the context of Special Olympics is recommending a safe and compatible program or activity for them so they can continue to be involved in their athleticism within Special Olympics. If they have dementia, and that's the realization with dementia, is it's sadly enough, it's a downward course. So when they have cognitive dysfunction, absolutely the kind of sports they may have been having or playing before, they might have to change it. Maybe the level or type of sport activity they were involved with, because their cognitive dysfunction getting worse, they might have to change to more simpler things. The instructions perhaps might have to be defined better in a different kind of way because they're not able to participate as much in listening or understanding or following instructions. Adding support, having a buddy, getting families and caregivers involved. And the other aspect of dementia I just mentioned, there's other things, is gait dysfunction, which is very common, and people would say Down syndrome and cognitive dysfunction, is they're having more problems walking and getting around or tripping and falling. So therefore, because of that nature, does that mean they stop playing? Does that mean they're out of Special Olympics? No, it doesn't have to be. It means that a change in activity can be very much important to them to keep them going, and having an assistant device such as a cane or walker they can use now, and that's important. And along the way, health promotion is always added to keep them going and healthy throughout the 24/7 a day and week and month and year. Connecting, this is with healthy communities, and this is a slide that really just talks about, and it really, I'll just kind of cut right to the chase, it just talks about the big picture about connectivity. Connectivity to many of the issues related in the community, health organizations, the USEDS, the University Centers of Excellence, the Alzheimer's Association, the National Down Syndrome Association, and I mentioned slides previously about Alaska and how Alaska themselves have age-related organizations, the ADRCs, the Area Agency Aging has different things. I did some research and I wanted to know about the Alzheimer's Association within Alaska, and it looks like the Alzheimer's Association in Alaska actually does not have a branch, and their closest branch is in Montana. I don't know if anyone knows any different on the phone about that. I spent some time talking during the day today talking to the National Alzheimer's, and they don't have anybody local within Alaska. I was quite shocked by that. So I was really quite surprised about that. So it's a realization what's really available to even reach out. There's a lot of partners. So in any kind of program, there's a lot of organizations that can be done from a promotional standpoint to work. AARP, when I turned 50, like most of us, I got that mailer from AARP. It's still, I haven't opened it yet. I was like, I don't want to admit I'm older, but it's still there. So AARP absolutely could be a partner within a senior athletes program. The Alzheimer's Association, my organization, the American Academy of Developmental Medicine and Dentistry, etc. So all this list, and this certainly doesn't include everybody, is absolutely partners within this program. Everybody can be holistic in a way to kind of work together. And I do show here the Center for Human Development at University of Alaska in Anchorage, who is the local USED, as you all may know, within your own state. So it's very important that they can do.
But what's needed? This is really basically my last slide. There's a lot of things it can do, and the first part again is relating to the realization that age-related change is realization affecting participation in sports. You need to have a baseline of what someone's function is. You really understand. You have to understand if you're going to develop a program, what is your goals, what's your outcomes, and how can you really measure them to determine whether your program is really being effective. Who internally is taking the lead? Here, God bless leaders of the organizations who are really motivated to want to take charge, forming the partnership they have internally. And what about the other states? What about national Special Olympics? What about international? Where does the whole large organization of Special Olympics? Because beyond my presentation today, I do this nationally and try to sell the idea nationally, and would love to believe that other state chapters or state or organization with Special Olympics, they would do the same thing. Why? This is not only Alaska issue. This is an issue for all of us around the country. Who are the state experts? Are there people in your state in Alaska who are the experts in age-related issues that could be given to consult with, to kind of help with? I'm making myself available in this webinar. In future, hopefully I can come out to Alaska. That would be a thrill of my life, to come and visit Alaska and be hands-on and talk and meet everyone. I would really love to do that, and we've had some discussions. How can the development of the healthy athletes or healthy community program be related? Health promotion, competition. What organizations, as I mentioned in the prior slide, can really be involved in helping support and marketing this? And then lastly is the cultural issue. The family issues are huge. They're very important to appreciate what it is with age-related decline and dementia related to participation and continuation of sports within Special Olympics. So I wanted to thank you for I guess 45 minutes. I guess I didn't do too bad. So I really want to thank everyone for listening, for what I was talking about. What I'm going to do is I'm going to open up the microphone if everyone's still there. Hello, everybody. Let's see if I could do this here. All right, I think I am. Wait, hang tight. All right. All right, folks, I'm opening up your microphones. I don't know if you can do that yourselves. Here, let's see. Okay. Now, do you hear me, Jim?
Yes, Seth, I can hear you.
Great. Jim, Nicole, I wanted to open up the microphone to you guys, and we talk about next steps, and I'll let you kind of give your comments, please.
Well, first of all, Seth, thank you so much. You're on the East Coast, and it's getting close to 11 o'clock. And thank you for all that you do for people with intellectual disabilities, and we're excited to have this webinar and for you putting the time in that you put in. Now, there's a group of people that we've invited to be on this webinar. Some may be involved with Special Olympics and some may not.
Right.
Really just want to open up, especially for Special Olympics, but for the provider agencies, is the Hope Resources and of Dr. Mabrion and a few others, we would like to begin a partnership with agencies, especially in Alaska, to begin tackling what dementia is and how we can form a statewide team to help this activity, also through clinical assessments. And especially now that we have a Fort Health Wellness Center that's applied for people with intellectual disabilities. So it's really open for everyone who's on, and we're interested in comments. And I think our next step is hopefully to invite you back in May or so and form a statewide task force so that we as advocates for people with intellectual disabilities start tackling the issues that people are experiencing with dementia and so on, and physical activity and nutrition.
Absolutely.
So, Nicole, is there anything you'd like to add to that?
No, I'm interested to know who's on the line, but we can. I don't know if Seth can tell that from where he's at.
I can. I mean, I can take a roll call. I mean, it's actually we have a small group, and I certainly don't mind hanging. I'm kind of, I got a lot of energy, and I'm kind of, I'm all good. I'll just take a quick roll call. I mean, I don't know if I can stay on for another 5 hours, and I'm going to probably destroy everyone's last name. Barbara Thorne. Hi, Barbara.
Yep, I'm here.
Carol.
Hi.
Hi, how are you? Carol Schuler? Hi, Carol. Damon Thompson?
Yeah, how's it going?
Hi, Damon. Welcome aboard. Daniel Canavan? Hi, Daniel.
Actually, Dan and Deb, both. How are you doing tonight?
Hey, guys. Hello. Joan Hamilton? Hi, Joan. Are you there? Lara Mabry? Hi, Lara. Lynn Ann 2? I see a hand raised up from Lynn Ann. Okay. So that's our group. That's who we have aside from you, Jim, and Nicole. That's who, you know. That's great. It's a nice small, small group. So if anyone has any questions, I'm open for dialogue, conversation. Does anyone, if you're going to have a question, please, state your name and if anyone have any comments.
Seth, this is Jim. Was Dr. Mabry, is she on the line?
Her name is listed.
Okay, maybe she's muted, but she is heads up our Special Olympics Alaska Healthy Athletes program.
Oh, wonderful. Okay, great.
And she's also giving a dissertation. She's a dentist, and we'll be speaking about the aging population in Colorado, I think, in March.
Oh, I see. Okay.
And but also, I just want to say that the awareness that you're bringing forward to even the people here, I think is just tremendous. And I think that we have a lot of opportunity in Alaska to move forward with this issue.
Jim, let me ask you a question. What have you? I mean, you've been in Special Olympics for how long, Jim?
I started as a volunteer in 1979.
Oh my goodness. Okay.
And I became the CEO in '96.
So tell me about your experience about age and what happens to the Special Olympics athletes as they age. What's your perspective?
My perspective is, in a lot, we have community programs and school programs, and we have a lot of young athletes. We have also athletes who are aging out. About 2 years ago, we had one of our athletes in our center here. Was the first time that I was aware of someone with Down syndrome with dementia.
Mm-hmm.
And so that is where, on this piece of where I got interested and started doing some research. And
Mm-hmm.
of course, our mutual friend, Dr. Perlman, was the one who...
Right, Steve Perlman, right.
So we are working out. We have a fitness center where athletes do work out 3 to 5 days a week. We're seeing a lot of improvement in all aspects of their life, from nutrition to physical activity. And I just believe that there is a place with our new facility that we can begin discussing putting a plan together. And I think all the things that you have said bring that out to as a community perspective, not just a Special Olympics perspective and the physical activity and
Right.
how we're going to change the look of competition for the aging athlete.
That's absolutely true. That's absolutely, yeah, and you'd be ahead of the curve. I mean, not to do a program because no one else is doing it, but I really think it would be huge to undertake this, because I really think a lot of the other states would gain amazing value for getting this kind of information. And not that I want to do a webinar for all 50 plus states, but I definitely think it would be something that would really set such a precedent. And I would like to think that from a national or international standpoint, that Special Olympics does really generate the motivation to really look at the aging senior athlete and creates a program. I see no reason why not. I see every upside. I can't find any reason why, anything negative about why Special Olympics wouldn't want to do it. And it's huge. I mean, it's a huge important issue that again, I already stated it many times, but I feel that way. Is there anyone else on the phone that has Anything else to add? Please do. I don't know if you can even talk. Hey, hopefully you're not all muted. I think you're unmuted.
Well, we're going to try this.
I'm sorry.
Dan.
Dan. Hi, Dan.
How are you this evening?
Wonderful. Welcome. Thank you for being
on. A little
on.
later for you.
It's all good.
I got just a couple of things. First off, watching the presentation, I noticed the age levels, especially for Downs, and I guess my question would be, would screening at an earlier age, is there a kind of a target age to begin really considering screening more intensely? And I guess secondly, this sounds just like almost an absolute no-brainer to start considering those shifts. And I have several very senior athletes out here in Kodiak. Have we tried to work very closely with some of the seniors agencies? I noticed Alaska Anchorage has basically a seniors Olympics,
right?
And it seems that would be the folks to draw from with the experience in dealing with aging, and then have them help us translate that to what that means locally for our Special Olympics athletes.
Well, let me kind of tackle. I'll tackle at least the first question. I don't know if I can speak much more about Alaska and what you have, but I'll give you my own perspective of what we've done before in other states. Is the issue of screening or the early assessment? We make the recommendation of starting at age 40. If we initially were hesitant and we were going to start at age 35 for Down syndrome, but we also looked at the realization of time and effort on staff and organization to do it at that younger age. And because it's still relatively small at 35, we thought there'd be a lot of false negatives. We didn't want to, or false positives. We didn't want to do that. So really, our recommendation is for Down syndrome to start the screening at age 40, and for people that have general IDD without Down syndrome, we think about starting it at age 60. Because people with IDD who don't have Down syndrome have the same rate and chance of developing dementia, Alzheimer's, like all of us. So that's really our general way of thinking about when to start the concern. The feeling about state and community partners is huge. And what we've done is that what I'm doing now with the webinar is not totally unique in terms of reaching out and trying to have the concept of partnership. What we've done within the AADMD National Task Group is that we've gone to a number of states and give webinars, not like specifically towards aging athletes, but more related to IDD and dementia. And we talk so much about partnering. So when we do our webinars and we actually do live presentations, I've done a fair amount of traveling to different states, is we bring in a round table all the partners, Dan, that you kind of alluded to. We bring in the aging people from the state. We bring in like a USED person. We would have someone from the Alzheimer's Association. We have people from Special Olympics, and we have them sit around the table with the idea in mind about partnership, about what's the point, what's the goal, let's develop relationships. So my own thought about anything to do in Alaska would be in that same vein, because I really think, I would see no reason not to believe this, that all the individuals who are related to IDD, both community, aging side, they're going to want to talk, because it all affects everybody. It's just different perspective from what their value or needs are, and I think it's a worthy conversation to hold, a panel, a conference call. That's up to you all, and then begin to agree that there's a need to have a dialogue and create something of a partnership. And each individual, each organization probably has their own perspective of how they value what they're going to get out of it. But that would be my thought. I'm not sure, Jim, as the top guy there, your perspective about next steps in terms of reaching out on. I mean, again, you don't have to obviously commit to what you want to do or how you want to do it.
I appreciate that. No. We're talking about Alaska. That would, we're not going to all of a sudden change all our focus on the aging population. However, I think our next step is that if you do come up in May, that we would have a few seminars to begin and beginning those partnerships to give us a couple of months to form a task force of agencies
right.
commissioners and from around the state to kind of begin speaking of how we as Alaskans would like to move forward.
Absolutely.
Not just Special Olympics.
Absolutely.
So it's a bigger picture, and all we're trying to do, and I know it's late, is just to give everyone a little taste of what it is that's that we could be looking at as we move forward in the next 5-year plan of how we tackle the aging population. So,
very good.
Next step now is to put together put together a task force of rural, urban, and have this discussion exactly what you're saying sometime later in May.
Definitely. Yeah, we'll talk about it.
Sure.
But again, it's late. I wanted to thank you again, everyone. I don't know if anyone has any last questions.
No, this is Lynn from CHD. Can you hear me?
Yes, hi, loud and clear. Hello.
Hi. I just wanted to let Nicole and Jim know that I'll talk with both. I can think of a couple of different ways that we might be able to work together, and even on current projects right now. So I'll follow up with you guys as well as the management when they get back from their national conference here. But Nicole, I've also sent you an email about a contact that someone might be good to have on your committee, Jim, as you guys expand this focus area, and she might be a really good resource for this. So I sent you an email already, Nicole.
Perfect.
Thank you.
Any final words? Any last before we're done? Anything else?
Seth, this is Nicole. Just really briefly, so everyone knows who's on the phone. So Jim and I are with Special Olympics Alaska. Damon is in a UAA class that I teach in regards to diversity and health promotion and fitness.
Mm-hmm.
And so Damon, thanks for taking time to be on. Dan and Deb Canavan are volunteers that run the program on Kodiak Island,
Mm-hmm.
and they also are very integrated in the community in Kodiak.
Okay. Great.
Leanne is from the Center for Human Development, which is much bigger than this, but it's part of UAA, and it's a great program to learn more about.
Okay.
And I didn't know where Barbara was from. Was there a Barbara on the call?
Barbara Thorne.
And if Barbara's still on, are you with Hope, or how did you end up on the call?
Hi, this is Barbara. I am with Hope, and there's about 7 other people in Anchorage that have been trying to get through on the phone with limited success.
Oh, I'm so sorry.
That's okay. At least, we hopefully will be able to continue to look at these slides. Your information was very informative.
Right,
so
and I'm going to archive. I recorded this presentation, so if the technology works as well as the technology should, then it's going to be archived. And Jim, once I get the link up for the archive version, I'll send it to you, and you could be the point of contact for maybe disseminating it. It'll be on our website, but I have recorded the presentation.
Barbara, thank you, Seth. Barbara, correct?
Yes.
I had an opportunity to meet with Steve Lesko about a month ago regarding this issue and or this webinar. We'll make sure and get it out. We're really sorry that the other 6 can't be on, but I think it's just a really good opportunity for all of us to get together and discuss this issue as we grow together on it.
Well, thanks for that. And actually, I'm getting a text message. Steve is listening, so he can. So,
oh, good.
We all appreciate the information that you're passing on, and we'll be happy to be able to see the archive material. So thanks for that as well.
Sure.
We'll share that with you for sure.
All right.
Okay, Nicole. Anyone else?
Anybody?
Nicole?
Those are the only names that I caught. I don't know if anybody else is on that wants to say anything or where they're from. That's probably it.
All right, folks. Thank you all so very much.
Thank you. Great presentation.
Thank you very much.
It's Barb again. I'm sorry. I just wanted to let you know that our medical director, Dr. Browner, he's listening to this as well.
Oh, good.
So everybody from Hope is really very invested in this, and really, we take this very seriously. So we definitely want to be a part.
Terrific. I look forward to it, and I avail myself to people when they email me. My email address is Seth Keller, Keller at AOL.com. So if you have any questions or you want to email me directly, please don't be shy and don't hesitate. I'm more than willing and motivated and able to communicate to each of you if you'd like to reach out to me personally. That'd be perfect. I would love it.
And just finally, we tried to find a day for Seth to come up a couple of months ago, and May is the closest that we could get him. I mean, that's how busy he is. And if it doesn't work out in May, we're still going to move forward. Seth, we want you to be our, our friend and mentor for Alaska, and we just can't thank you enough for being up almost at 11 or 12 o'clock, 11 o'clock at night in New York or Eastern time.
Yeah, I see the lovely, when I went on, I wanted to put some beautiful pictures of Alaska, and I was salivating, like, what a beautiful state you guys have. I was going to say, New Jersey's wonderful too, but it doesn't share, it doesn't compare.
And I appreciate the polar plunge picture, too.
There you go. As you noticed that, that was funny. I'm glad you picked that up. Right? That was right. That's what you guys do. Don't expect me to jump in a bunch of water here. Oh, my goodness. Wow. You guys are really, wow, that's tough. Okay. All right, everybody.
Thank you, everyone. And we'll get together with Steve, and we'll move forward.
Very good. All right, good night, everybody.
Thank you, Seth.
All right, bye-bye.